Hello, and thank you for joining us for this session, Managing Recurrence. I'd like to thank our sponsor, Clovis Oncology, for making this session possible. All ovarian cancer survivors worry about recurrence. And in this session, Dr. Stephanie Wethington will discuss the diagnosis and management of recurrent ovarian cancer. Dr. Wethington is an assistant professor of OBGYN at Johns Hopkins, where she's also the director of the Gynecologic Oncology Survivorship Program. You can view her full bio on the conference website. Thank you for being here, Dr. Wethington, and I'll turn it over to you.
Hi, everybody. Thank you for joining us today. We're going to talk about managing recurrent ovarian cancer and how to chart your path. My name is Stephanie Wethington, and I'm an assistant professor at Johns Hopkins Medicine in Baltimore. And I have the pleasure of directing our survivorship program, which is one of the elements of my job that I enjoy the most. And that sort of brings me here to discuss with you all today some strategies and some theories and sort of a framework for how to think about a recurrent ovarian cancer diagnosis and all the many elements that come along with it. I have no financial disclosures. I do have some academic interests and research interests. And so you will notice me mention throughout some things about PARP inhibitors. And so while I have no financial disclosures, I do have academic interests in research projects into PARP inhibitors. So ovarian cancer. What is ovarian cancer? It's a term that gets thrown around, and I have to apologize to all the folks who are listening today who don't have epithelial ovarian cancers, because although there are three main categories of ovarian cancer, sex cord stromal tumors, germ cell tumors, and epithelial ovarian cancers, over 90% of ovarian cancers are epithelial ovarian cancers. And most of the time, when we launch into discussions or talks about ovarian cancer, we unfortunately lead into more of a discussion about epithelial ovarian cancers. And we do this because they are the more common, right? So over 90% of ovarian cancers are epithelial ovarian cancers. They also tend to be the ones that are more aggressive. And in the current era, there tends to be a lot more research and active areas of investigation going on. And so they do tend to get more attention. They shouldn't get all the attention. The other ovarian cancers are equally as important. And certainly we have as much to learn about them as we do about any of our other cancers. But I will sort of give a disclosure, one final disclosure about my talk today, which is that although I'm going to talk about ovarian cancers, I'm going to try to integrate in some commentary on germ cell tumors and sex cord stromal tumors. Much of what I say today will be most closely applied to epithelial ovarian cancers. The other disclosure I have is that although I'm going to say ovarian cancer for the remainder of my talk, I do actually mean ovarian, primary peritoneal, and fallopian tube cancers, because all three of those come from, in the case of the high-grade serous epithelial ovarian cancers, fallopian tube cancers, and primary peritoneal cancers, actually from the fallopian tube. And so you see the graphic on the right side of the screen. It shows the end of the fallopian tube. And since about 2007, 2008, we have developed an increasing understanding that these high-grade serous ovarian cancers actually originate in the fallopian tube, in the fimbria. That's where we find precursors to these cancers, and they flake off. So those cells fall out of the fallopian tube, those fingers at the end of the tube, and onto the ovary or onto the peritoneum, and that's where they grow. So for many generations of physicians and patients, where we found them was where they grew and not where they came from. And through some elegant molecular biology and a lot of risk-reducing surgeries that gave us some elegant epidemiology, we've been able to better identify that actually when we talk about the high-grade serous, quote-unquote, ovarian cancers, we're actually most of the time talking about fallopian tube cancers that come from the fimbria and spread from there. So the other disclosure I will add is that if I say ovarian, fallopian tube, and primary peritoneal, every single time we will be increase the length of this talk by an hour. And so I'm just going to say ovarian cancers for the remainder. And everybody should know I'm including all of these different sites of origin. So what is a cancer recurrence? A cancer recurrence, there's lots of different terms that get used: remission, recurrence, You'll hear the term NED, AWD, different terminology. So I would say for the rest of our talk, really what we're talking about when we're talking about a cancer recurrence is once it's come back. And so it can come back anywhere. Cancer recurrence can occur in the same type of location. And for the high-grade serous ovarian cancers, this is most commonly in the abdomen or the pelvis, in the peritoneum, and that lower center graph there with the white arrows shows an example of a recurrence in some residual momentum in the peritoneum. And so you certainly can occur in the same place. It can also occur in distant places. So we have an image on the right lower of the liver or in the upper middle of a recurrence in the brain. And so a recurrence is any return of the cancer. And I think what sometimes gets confusing is even when it is in the liver, even when it is in the brain, even when it's outside or away from the original place it came from, it is still a recurrence of that type of cancer. And that's a little bit what distinguishes something that's a cancer from a non-cancer. The ability to spread and grow elsewhere in the body and to grow without the organ of origin. So we take out the ovaries, we take out the fallopian tubes. There's no way to get that primary germ cell tumor, sex cord stromal tumor, or epithelial tumor again in the ovary. The way it makes a cancer is the ability to grow elsewhere in the body. So a cancer recurrence is a cancer coming back in a site that's distant or elsewhere from where it started, in that case, metastatic recurrence. And for some women who have a sex cord stromal tumor or a germ cell tumor, those types of cancers of the ovary, sometimes we only take out one ovary and we leave the other ovary in. And so sometimes a recurrence is in the other ovary. And so a cancer recurrence is any return of the cancer after the original treatment was completed. I think what's hard about cancer recurrence is that when you have a cancer recurrence, it's a little bit like looking into a crystal ball to predict the future. And all of us want to know, well, once it comes back once, what do I expect? And if it hasn't come back, folks ask, is it going to come back? And that's a little bit prediction of the future that we can't quite ever make. And similarly, once it comes back, we enter into a journey that's very hard to predict. The only thing that anybody who helps patients through the process of a cancer recurrence can guarantee is that there will be surprises. There will be the unexpected. And so in that sense, that's why a journey sort of analogy can be a good one. And unexpected journey elements are a very important part of cancer recurrence. And so setting up your team and setting up your process and understanding the terminology and hopefully what I'm going to lay out for you today will be helpful in sort of figuring out how to take the unexpected, unforeseen set of circumstances, the inability to look into a crystal ball and predict the future, and provide some context that when you have those changes and bumps along the way, maybe some of these elements are not as unfamiliar as they might otherwise be, and it's easier to adjust. So how do we categorize cancer recurrences? In ovary cancer, we focus on this terminology of platinum sensitive and platinum resistant. And platinum sensitive is any cancer that's returned more than 6 months from the last platinum treatment in specific. And platinum resistant is when it's less than 6 months. And then platinum refractory is a cancer that actually grows while receiving platinum. Platinum is a category of chemotherapy. Cisplatin and carboplatin are the two platins that we most commonly use to treat gynecologic cancers. So beyond the categorization of the platinum sensitivity, there are categories of treatment options in the recurrent setting. And I sort of break it down into two different labels that we assign. One label is standard of care versus a clinical trial. So standards of care are potentially FDA approved. There's a series of drugs that have all been FDA approved for use in ovarian cancer specifically. And then there are actually some therapies that are not FDA approved specifically for ovarian cancer, but may be approved in another cancer type, but are NCCN compendia listed. NCCN is the National Comprehensive Cancer Network. It is a coalition of over 40 different comprehensive cancer centers that come together to set guidelines. And this is used as a standard of care to determine sort of what are the accepted treatments that have sufficient data supporting them. This is actually used by many insurance companies to determine coverage. So these are standards of care accepted with a certain label or criteria or sort of check mark from a governing body of some sort. And then the other label, in contrast to a standard of care, would be a clinical trial, something that's under investigation, something we think might have promise, but we don't yet have that standard of care label for it yet. And we'll come back and talk more about clinical trials. The other way that treatment options are categorized is by what the treatment type actually is. Is it a surgery? Is it radiation? Is it a systemic therapy? Surgery and radiation tend to both be focal treatments or treatments localized to a part of the body, surgery, the abdomen and pelvis, or sometimes in the lungs, sometimes in a lymph node in the groin. So surgery tends to address locations of disease. Radiation similarly tends to be focused on an individual body part and not on the entire body. When I mention systemic therapies, I'm talking about things that get infused or taken by mouth and then circulate throughout the entire body. So these are cytotoxic chemotherapies, targeted agents, things like bevacizumab or PARP inhibitors, hormonal therapies. People don't think about hormonal therapies in the same way that a cytotoxic chemotherapy might be considered, but actually they can be highly effective, particularly if you have a low-grade serous ovarian cancer, a low-grade endometrioid, or perhaps a granulosa cell. So there's a variety of settings in which we use hormonal therapies. And then some of our newer systemic therapies, immunotherapies, so things that use the immune system in some way to garner a response and to decrease cancer or treat cancer. So we have two labels, one label, whether it's standard of care in one clinical trials, and a second label, the type of treatment that it is. And we can take these categories of platinum sensitivity, resistance, or refractory, as well as these different labels on the treatment types, and we can think about how to categorize our treatments. We also categorize our cancers. And in epithelial serous cancers, especially the high-grade epithelial ovarian cancers, we now categorize our treatments in some part based on homologous recombination deficiency or BRCA mutations, all of these categories or labels sort of getting at how DNA repairs itself and what might be the origin of the malignancy. And we've learned over time that about 50% of high-grade serous ovarian cancers actually have an abnormality in homologous recombination, which is a DNA repair mechanism. And that is a driving force in the development of the cancer. For about 15 to 20% of these people, it might be a germline or an inherited mutation. It's by family history, knowing your family history. If you are an epithelial ovarian cancer survivor, telling your family your history so that they can get tested is so vitally important, because sometimes these cancers do have an inherited risk component to them. The BRCA mutation is probably the one most people are familiar with. Also, Lynch syndrome is another syndrome that can be associated with ovarian cancers, and as well endometrial cancers, actually in the GYN space. So certainly these categories of whether a tumor is HR deficient or not, and the means by which it is HR deficient, is another way in which we now categorize our epithelial ovarian cancers, particularly the high-grade serous type. There's been a lot of elegant science that has gone into this. And we use this categorization because it helps us predict response to certain treatments, specifically PARP inhibitors. And we know that it has some prognostic information. It tells us about how patients respond to treatments overall and how their tumors behave. So if we put all these together, we ask ourselves, how do cancer recurrence and how do the treatment categories, how do we put all these together and make them relate? In each of our categories, platinum sensitive, resistant, and refractory, there are different treatment options. So in the platinum sensitive setting, sometimes we talk about surgery. Granulosa cell tumors are a certain tumor type that it is very common to address recurrences, even multiple recurrences with surgeries, as it's often quite resectable, quite indolent and slow growing, and therefore quite amenable to surgery. We also use surgery in the platinum-sensitive setting for high-grade and low-grade serous ovarian cancer recurrences. So surgery can be an appropriate option in the platinum-sensitive setting to discuss with your physician. Radiation is not commonly used in the platinum-sensitive recurrent setting unless the location of the tumor warrants it. So some people experience recurrence in a bone, perhaps, or in the brain, and we're more apt to use radiation in those settings. But systemic therapy is a significant part of our recurrent treatment options, and carboplatin doublets for those who are platinum sensitive, single agents for those who are platinum resistant. Targeted agents such as bevacizumab and the PARP inhibitors are used very frequently in the recurrent setting across all the different categories, as are clinical trials. So I mentioned surgery for recurrent disease, and this is something to ask your physicians about. We have multiple clinical trials that provide supporting and conflicting information. And I have here what I call the doctor way to look at all the data. So all of our Kaplan-Meier curves. We love as physicians to look at our Kaplan-Meier curves and see a snapshot of what the results are like. And this snapshot I put up to make the point that surgery is not appropriate for all patients, but it is appropriate for some patients. And the Kaplan-Meier curves that you're looking at here are focused specifically on surgery in the recurrent setting. And as you can see, sometimes surgery is the top curve and sometimes it's the lower curve. And so I say this to say it's a topic of conversation you should have with your physician, your oncologist. Is surgery an appropriate therapy for me in the recurrent setting? If so, yes. If no, why? And there are a variety of studies that parse out who the ideal patients are based on how many sites of disease, how long it's been since there was last evidence of disease, prior therapies, whether there's fluid in the belly called ascites. So there's some criteria that we use to help us guide whether or not surgery might be an appropriate option. You may hear friends who have ovarian cancer recurrence describe that they had surgery or didn't, and maybe you did or didn't. And the reason there's a variety of approaches is because there really is a variety of best recommendations based on specifics of patients and some conflicting data that leaves room for interpretation. Radiation for recurrence, I mentioned, tends to be focused on specific locations. Radiation is a very good targeted therapy. And so it can be quite excellent at getting at some symptoms. So for instance, if you have some cancer in the bone, it can be very good for palliation of pain in the bone and for treating bone metastasis as well as brain. Sometimes we use it for liver metastases or lung areas. So a variety of different settings, but tends to most commonly be used for focal areas as opposed to diffuse disease. Systemic therapy. So this is where the majority, vast majority of our therapies fall. We are fortunate that we have had in the last 10 years a real influx of treatment options that didn't exist before. And you can see in my graph here, the lower left, these are some of the FDA approvals in ovarian cancer. I focused predominantly on single agent approvals. There are multi-agent approvals for things like BEP for some of the germ cell sex cord stromal tumor types, which is one of the regimens. Also approvals for some combinations like cisplatin and gemcitabine or carboplatin and paclitaxel. So we do have some combination FDA approvals, but I focused here on the single agents. And what you see is that the vast majority of our graph from 1960 to 2010 falls on the left side, is the greatest amount of time, but has about the same number of approvals as our 2010 to the present day has. And fortunately, as that molecular understanding that I mentioned about the underpinnings of ovarian cancer has come along, so too have our therapeutic options and therapeutic interventions. And that olaparib, rucaparib, niraparib triad that you see there down the middle from top to bottom in the 2010 to 2020 segment of our graph, those are our newest agents in the PARP inhibitors that have come onto the field predominantly for high-grade serous epithelial ovarian cancers. Pembrolizumab is noted on there, and that's one of our immunotherapies that is approved, as well as some combinations. And you can see the table that I took from the NCCN guidelines on the right there gives you a list, and there are a lot of options and a lot of specifics and new ways that we parse out what's right for different patients in different moments. But as you can see, there are a lot of options in the treatment, systemic treatment arena. Now, how does cytotoxic chemotherapy work? Well, there's a lot of different mechanisms by which cytotoxic chemotherapy works. And much of the mechanism of cytotoxic chemotherapy has to do with cell growth and replication in different ways in which agents disrupt the process of cell growth and replication. Each of these different agents tends to do it in a rather non-specific way, as opposed to a targeted agent, which may do it in a more specified way, targeting particular cells with particular abnormalities. So cytotoxic chemotherapy agents, ones that I've mentioned already that would be relevant in this case, are carboplatins, or cisplatins, or paclitaxels, or Doxil, or liposomal doxorubicin, or doxorubicin, or gemcitabine. All these agents work by disrupting the process of cell replication in some way, shape, or form, and thereby causing cell death. And that is also how they get their toxicities. So their toxicities come from the indiscriminate effect on other cells in the body, most commonly cells that are replicating quickly. So that's sort of how a brief overview of how cytotoxic chemotherapies work. In contrast, let's talk about PARP inhibitors for a minute. I've mentioned these a few times. PARP inhibitors are an example of a targeted agent, and they target DNA repair pathways. And there are multiple DNA repair pathways. Cell replication, DNA repair, these are critical processes in our body, and they need to function very well in order for our cells to replicate and our bodies to continue to work, and cancers actually not to develop, because the DNA repair pathway corrects any errors in our DNA that may potentially lead to a cancer. And so in the normal DNA repair pathway, if you have a single-stranded break, that single-stranded break might be repaired, for instance, by base excision repair. If it doesn't get repaired, remember the double helix that we all learned about when we were in high school? If that single-stranded break doesn't get repaired, it becomes a double-stranded break. And if that double-stranded break then needs to be repaired, and double-stranded break repair, particularly homologous recombination in specific, homologous recombination is a high-fidelity, elegant mechanism. It's our most reliable mechanism of double-stranded DNA break repair and therefore of DNA repair. And so that process becomes very important. PARP inhibitors, in our graph on the right, are a drug that interrupt the single-stranded break repair mechanism of base excision repair. They have many different functions, but that's sort of one of its core functions. So PARP inhibitors disrupt the single-stranded break repair, and then you develop double-stranded breaks. And I mentioned earlier that about 50% of the high-grade serous epithelial ovarian cancers rely upon homologous or have a homologous recombination deficiency. So if the PARP inhibitors take away your single-stranded repair mechanism, and underlying the cancer is a double-stranded repair error, then you put those two things together and the DNA is not able to be repaired by the cell. And so therefore the cell enters into apoptosis and cell death. And so it's sort of a two-hit process that leads to cell death. And that's why it works. And that's why when we start to categorize our cancers, we often will discuss whether a cancer has a homologous recombination deficiency, and why when we think about that deficiency, we think about PARP inhibitors as being more efficacious in those tumor types. And so that's how our PARP inhibitors work, and that's how a targeted agent works. And what we have found is that actually they work incredibly well. Most commonly used today in the maintenance setting, in the upfront maintenance setting, in the platinum-sensitive recurrent maintenance setting, and in treatment, especially for patients who have germline BRCA mutations. So the PARP inhibitors have been shown to be extremely efficacious, and greatest benefit shown in patients who have homologous recombination. And here we have a return momentarily to a Kaplan-Meier curve, but what you can see by just glancing across it without getting into any of the details, the blue line in all of these graphs is the PARP inhibitor line, and the red line at the bottom is the placebo. And so what you see is that PARP inhibitors do a good job of raising that survival curve up, and that is why there's so much attention, so many new FDA approvals, and so much work going into PARP inhibitors. Another targeted agent that we use a lot are VEGF inhibitors. And VEGF inhibitors inhibit blood vessel growth development. And the most common VEGF inhibitor that folks have probably heard about is Avastin or bevacizumab. And this is the VEGF inhibitor that is actually approved for the use in ovarian cancer. We use it in the primary setting sometimes, in the platinum sensitive, in the platinum resistant. So it crosses across our different time points. And what the VEGF inhibitors do is tumors normally secrete VEGF so that blood vessels grow and bring more blood flow to the tumor so the tumor can grow bigger because it has the nutrients it needs. So if you introduce a VEGF inhibitor, the tumor is not allowed to grow the blood vessels, and therefore the tumor can't grow as big, or in some cases it actually begins to die because it runs out of blood supply. So that's the sort of a basic of how they work, but it makes sense. Tumors need blood flow, they need nutrients. Take that away, and you're going to take away the ability of the tumor to grow. So that's how VEGF inhibitors or Avastin work. And that's why when you are on Avastin, for instance, you may experience or notice high blood pressure, protein in the urine. The toxicities of a VEGF inhibitor tend to focus on things related to blood vessels. So it sort of makes sense why that might be. So immunotherapy. So there are a variety of different strategies that are under investigation to use the natural immune system in order to stimulate response to tumor cells. And one example is CAR T cell therapy. This is still under investigation, not yet FDA approved or available, but there are multiple clinical trials that are ongoing and that have been reported in part or in whole. And in the case of CAR T cell therapy, you actually have a patient, you take some of the blood and you isolate the T cells, then you alter those T cells to sort of stimulate their growth and development, and then you reinfuse them, and it stimulates increased growth of T cells inside the body to target specifically the tumor. And so this process is something that is currently in the clinical trial phase, but is something that you might hear about quite a bit in the media and is being investigated. Checkpoint inhibitors. So tumors have to hide. They need blood flow in order to grow, and they need to hide actually from the body because our immune systems are really elegant. If they see a foreign invader somewhere, our bodies will actually go to that location and take care of that foreign invader. It's how our bodies address viruses or bacteria, all sorts of different things. And tumors are actually no different, except tumors are tricky. And tumors create a shell around them or a way of hiding from the immune system. And checkpoint inhibitors inhibit the ability of the body to recognize that tumor cell. So in the case of PD-L1 or pembrolizumab is probably the agent that most people most commonly hear of that works in this way. Pembrolizumab blocks the receptors that allow the tumor to hide from the natural immune system. And therefore, the tumor isn't able to hide, and the T cells are able to identify the tumor again and address the tumor and kill it. And so that's sort of it's a way of unhiding or taking away the ability of the tumor to hide from the natural immune system. And that's how things like pembrolizumab, for instance, work. Pembrolizumab is approved, not specific to any cancer type, but specific actually to an abnormality in the cancer called MMR or mismatch repair. And so if you have a mismatch repair deficiency, that's a different mechanism of DNA repair. And so if the tumor has that, then it is more susceptible to pembrolizumab. So pembrolizumab is approved for use in ovarian cancer for those patients who have an MMR deficiency in their tumor. So it's a very specific approval. Similarly, vaccines. New York ESO-1 is probably the vaccine that has been most heavily studied in ovarian cancers. And the idea is similarly to stimulate the natural immune system to attack the cancer cells. So clinical trials, I've mentioned them a few times. I've mentioned them in a few contexts as a treatment option category at large, as well as specific when we were discussing CAR T cell therapy or vaccines and immunotherapy space. So how do clinical trials sort of work, and what's the design, and how do you sort of figure out for yourself where you fall in this? So a clinical trial is asking a question. So unlike a standard of care where the question's been answered, a clinical trial is designed to answer a specific question. In the case of a treatment trial, a clinical trial that's focused on a treatment intervention, they could be designed to answer a question about safety. Is the drug safe? Those tend to be our phase 1 trials. Is the drug efficacious? So does the drug work? So that phase 1 gets to the safety, gets to the dosing. When we get to our phase 2, we're looking at the efficacy. Does the drug work? And with each increasing phase, we give it to a larger and larger number of people. So in the phase 2, we give it to a cohort of people. We see how commonly it is effective and decide whether or not we're going to move it into the phase 3. So when we get to phase 3, the question that we're asking is, does this new agent, does this new combination work as well as or better than something that's current standard of care? So in the phase 3, you're comparing a standard of care to something new. And it could be new because it's a new combination, or it could be new because it's a brand new drug. And it varies depending on the specific clinical trial. And actually, even once something makes it through the comparison phase, even once something is FDA approved, we will still do post-market surveillance. We'll still do follow-up. There's still reporting to the FDA and safety data gathering, and sometimes additional trials to document patient experience with an agent. And so we sort of have 4 phases of the clinical trial design. So where do you find a clinical trial? There's a variety of different ways actually to identify a clinical trial that you might be eligible for. Clinicaltrials.gov is probably one of the most common places. And the OCRA webpage actually has a clinical trials finder that is extremely helpful, as well as a clinical trials navigator who can help. And I think one of the things that if you cast your mind back to that table I had about what are the different options, you'll notice that I had always both standard of care and clinical trials. So one thing I think is always important to remember is that when a physician says to a patient, there's a clinical trial I would like you to consider, or some phrase such as that, they're not saying there are no options. They're not saying there is no hope. They're saying there's a clinical trial I'd like you to consider. And the clinical trial could be anything from the phase 1 to the phase 4 category. And it could be a brand new drug. It could be a different combination. It could be taking something you get already and adding something and seeing if that addition is beneficial. There's a variety of different questions, a variety of different contexts in which clinical trials happen. And no assumptions should be made ever about that phrase, there's a clinical trial to consider. There are actually clinical trials in the primary treatment setting, just like there are in the recurrent setting. So and everybody has different comfort levels. So some patients are comfortable considering a clinical trial. Some patients don't want to consider. Some patients want to consider but not enroll. Some patients want to consider and enroll. Some people want to do more than one clinical trial. So it's very individual. But I would never take the raising of a clinical trial as an option, as a statement about prognosis. These 2 things are completely separate. Sometimes the reason a physician brings up a clinical trial is that it's the only way to gain access to the newest, potentially greatest next thing. And so it can be viewed in a variety of different contexts or a variety of different ways, depending on the specific context. So that means when a clinical trial is raised, it's extremely important to ask questions so that you feel comfortable that you understand. What is the question the clinical trial is asking? In what setting is it asking this? In what phase is it asking this? What is the experience with this agent or these agents previously that is serving as the basis for this clinical trial, so that you have a greater understanding. And hopefully, what my hope would be is that everybody who wants access to a clinical trial is able to use one of these websites, is able to reach out to their physician and find a clinical trial that suits them best. So clinical trials can be hard to find. They're not always easy to find. In fact, we did a webinar series during the COVID era when we couldn't have our annual conference. And one of the such things that we talked about was clinical trials. And I called it a needle in a haystack. That was the name of the talk. And the reason is that sometimes they can be very difficult to find the right one for you. So there may be lots of clinical trials, but not the right one for you. Or there may not be lots of clinical trials where you are. So sometimes it does take asking your physician about whether referral to a tertiary or quaternary center would be beneficial. So clinical trials, you can tell I'm spending a lot of time on this concept because I think it's an important component of management of recurrence. And if you're comfortable with it, and an important thing to ask about and to be inquisitive about, even if you decide not to do it, just to know. So what other treatment options? We have focused up until this moment on things that people think of classically as the treatment options: surgery, radiation, chemotherapy, but there's actually a tremendous number of other elements in the treatment plan. Part of the challenge of managing a recurrent ovarian cancer diagnosis is that the treatment plan is super complex and has lots of different elements. Nutrition. Sometimes it's nutrition for the purposes of health. Sometimes it's nutrition because the recurrence is sitting on a piece of bowel, and if you adjust the diet, your bowels are more comfortable and you feel better. So sometimes it's nutrition for purposes of healthy diet. Sometimes it's nutrition for purposes of managing symptoms. So nutrition is an important element of the treatment strategy. Exercise, keeping the body moving, keeping the circulation moving. And I say exercise, and actually in the last year, I've come not to use this term. And when I updated my slides, I should have taken that out. I should have said movement, because exercise has a certain connotation to it, but movement, be it yoga, be it walking, be it jogging, be it intensive exercising, be it swimming, whatever it is for you that creates movement and energy in your body, that is part of the treatment plan and keeping the body moving. Intimacy. This is part of our treatment plan. It's part of our general well-being, as is our support network. And leaning on friends and family and other cancer survivors through groups like OCRA or NOC or other institutions that all have tremendous networks of people who all want to help each other through the process. Primary care doctor, while you're on treatment, managing the diabetes, the hypertension, the thyroid issues, all these are equally important. And so integrating your primary care doctor into your treatment plan is very important. Palliative medicine, clergy, social workers, psychiatrists, psychologists, all of these also play a role in our well-being and in setting up our treatment plan, as well as integrative medicine specialists. And maybe this is massage, maybe this is acupuncture, maybe this is other medications. Some people turn to things like turmeric or mistletoe or vitamin C, or some of the most common things that I hear mentioned or named by patients and asked about. Mushroom is also increasingly asked about and questioned. And I very purposefully used the phrase medications in front of this to make the point that all of these things can be integrative medicine. All of these things can be safe to use, but all of them are actually medications, meaning they cause physiologic change. That's how I mean that term, medication. And so it is incredibly important to make sure that they are part of your treatment plan and not not out separate, but integrated into your treatment plan to make sure that they're used safely. And there are safe ways always to do this. But it does need to be an integrated approach and a together approach. I mentioned palliative medicine. And I mention this because I think there are a lot of misconceptions, and I think it's really important to break down the misconceptions and integrate the use of palliative medicine into your treatment plan. There can be different types of palliative medicine. There can be primary or secondary, meaning sometimes the oncologist who's taking care of you will integrate the palliative medicine elements into the treatment plan and care automatically, and sometimes it's a specialty. So it is a medical specialty now in 2021. There are individuals who are boarded in palliative medicine. They've done additional training called a fellowship in it to develop their skills and their knowledge base. It is a care plan or a care process, a care strategy, a care philosophy. You can pick your term that you want to use there, but it's a care philosophy that's guided by the needs of the patient and not by the cancer prognosis. And the goal is to improve how you're feeling, improve quality of life, improve symptom management. I've heard some people, a very esteemed palliative medicine colleague of mine, call it sort of your quality of life coach. It's somebody who, yes, they are going to ask you about how things are going with your cancer, but they're also going to have some dedicated time to ask about symptoms you may be having, be it pain, nausea, vomiting, constipation, things that happen quite frequently, but also symptoms like anxiety or depression. If you're having any shortness of breath or loss of appetite or fatigue and trouble sleeping, all these things that have incredible impact on the day-to-day, they are really there to help focus on, because the reality is when you're in my office, your oncologist's office, there's a lot we're talking about, and we're very focused on chemotherapy, surgery, radiation, clinical trials, and that takes a lot of time. And sometimes if you have access to a palliative medicine specialist as an independent person, it can be very beneficial to providing you an outlet to focus less on that cancer-directed therapy and more on a you-directed therapy. And this plays out not just in sort of something that sounds nice or a touchy-feely thing, but actually something that in now multiple clinical trials, first reported in the New England Journal of Medicine in 2010, the graphs I have here are the first time this was published, that early palliative care, involvement of palliative care specialists actually improves not only how patients report their feeling and doing, but also survival. And so think of it as integrating in another treatment strategy or another treatment plan or another treatment partner, both to help you feel better, but also it's been shown to improve survival. So it is actually a medicine in and of itself. Now, what about caregivers? I mean, what a critical part of the recurrent ovarian cancer journey and plan, an invaluable strategy. And so for those who are caregivers who are listening right now, that this first line is for you. So taking care of yourself as a caregiver is your first priority. So I think part of what happens to many of our caregivers is they are so focused on the patient that they forget to take care of themselves. So caregivers play a role in the treatment plan by taking care of themselves first, so that they are then able to help with asking questions, finding resources, accessing resources, going to doctor's visits, making the treatment process easier for the patient, providing support, both physical, getting places, doing things, and emotional. And so there are a tremendous number and a growing number. And I actually think even more so than patient resources, of late caregiver resources are growing even more exponentially than patient resources out there and available. And in the post-COVID era, when everything's kind of gone online and gone virtual, so many of them are online and available. So online support groups, mentor groups, and group and individual therapy opportunities. So for the caregivers, they are a critical part to our treatment plan. For the patients, saying yes to every caregiver offer of help, making sure that your caregivers are taken care of, and for the caregivers, making sure you're taken care of and finding good resources is very important. And there's a lot of good resources out there. So I want to end on sort of the final piece. Managing a cancer recurrence, I started with the crystal ball and that view of looking out into the abyss of space and stars, and just that distant feeling that image evokes. And what I want to end with is sort of the opposite of that, which is the together feeling that actually all of this invokes, be it our caregivers, our support networks, our friends, our online resources. There is actually a tremendous amount of inspiration. And so as one sets their treatment plan and sets up how they're going to approach and address the experience of a recurrent ovarian cancer, it's very important to ensure that you draw inspiration into that plan, or you decorate that plan with a healthy dose of inspiration, getting it from the tremendous research that's going on all across the country, in laboratories and in offices, in clinics, in the clinical research setting, in the clinical trials. The hard work of innumerable scientists for whom we are grateful, that bring us inspiration in what they have accomplished, and really in very short times as we've come to understand the molecular underpinnings of these tumors. Inspiration in the writings of others, and there's a variety of books out there that have been written both by patients, probably most famously, I don't know if famous is the right word, but most known, that memoir of a debulked woman, that was written, as well as by family members. And one that's excellent and very humorous, When I Die, Take My Panties. So I've got some images down here of some great book options, but there's tons of writing. You can draw inspiration in your own writing. There's a large number of people who have blogged and put their blogs online that you can read to draw inspiration. And then from other survivors, and certainly from our own community of ovarian cancer survivors, and then from very famous survivors who survived, multiple bouts of malignancy and kept working, kept on keeping on throughout the process. And the bottom picture there, where you see that group of women, those are all individuals who I've had the pleasure of meeting, and they did a video as part of an awareness campaign. And every time I see this picture, it makes me smile. So finding inspiration in others and in outward areas, as well as within your own family, from your family and friends. So the last part of your treatment plan, be sure to draw some inspiration into how you're strategizing your approach to recurrent ovarian cancer, and finding a bit of inspiration anywhere and everywhere you possibly can. I am done with the lecture part. For those of you who have questions, please bring all your questions to the Q&A. We'll be having a Q&A to answer questions that may have arisen in the course of listening to this talk today. So thank you for joining me, and I hope I get to see you at the Q&A, and I hope that you bring all the many questions that came up in the course of listening today.